Hello. Thank you so much for joining us this afternoon. If you are joining us this afternoon, and if not, thank you so much for just participating in this GAP MASLD MASH Community Network program sponsored by Madrigal Pharmaceuticals. So just to let you know, my name is Cheryl Walsh. I am a nurse practitioner in Springdale, Arkansas. Actually, it's more like Northwest Arkansas, the northwest corner of Arkansas. And I am a participant with GI Alliance. I've worked with them for several years, and I've been a nurse practitioner in GI hepatology for 15 years in December. So this is a QR code if you'd like to register for the meeting. So give it a try if you'd like to. And today we're here really just to talk about MASLD basics, just to sort of give everyone a glean into this type of disorder. So we're going to start here with the nomenclature. This is a new nomenclature, MASLD. It's a shift in how we name and call fatty liver disease. So most of the time we have known that this has been called NAFLD, non-alcoholic fatty liver disease. And this term has been replaced. And if you can see here over the top, it says steatotic liver disease. That's what the replacement is there for. But then when we look over on that left side, we see metabolic dysfunction associated steatotic liver disease, or MASLD. And this new nomenclature is a terminology that's been brought about to lessen the stigma associated with liver disease. And it's really more in line with the typical underlying causes and biology of this disease. So we see that steatotic liver disease, SLD, and we see that it's subdivided into groups based on the underlying mechanism. So that first one, MASLD, metabolic dysfunction associated steatotic liver disease, which is definitely a mouthful, right? And then we move over towards the right, and we see that there's MASLD and increased alcohol intake, and we call that MASLD. And what's really interesting, at least I found it quite interesting, is that when we're looking at alcohol usage in our patients, 6 ounces is actually the equivalent of 170 grams. And I know that a lot of people are not necessarily drinking only 6 ounces, and that is on the very low end of that MASLD. And then once we move over to that alcohol associated related liver disease, we see that that ALD predominant is 350 grams to 420, and that is really not that much alcohol, and that's on a daily basis. So greater than 2 drinks a day for females, greater than 3 drinks a day for males. And then as we keep moving over to the right, we see other specific etiologies that go with that steatotic liver disease. We can see drug-induced liver injury. We can see monogenic diseases such as Wilson's or hepatitis C, genotype 3, and then miscellaneous, and then moving even all the way over to the right, we see cryptogenic, meaning we aren't really sure with the assessment that we've done where that steatotic liver disease is coming from. So then, what is actually the definition of MASLD? So MASLD, the definition revolves around steatotic liver disease, and it's hepatic steatosis that's identified by imaging or biopsy. And then it's in addition, we find that MASLD, MASLD, is also in conjunction with cardiometabolic risk factors. At least one of these risk factors is involved in the definition of MASLD. And you can see over on that right side that when we have at least 1 out of that 5, and we look at that adult criteria, we see BMI greater than 25 kilograms, or we see fasting serum glucose, or pre-diabetes or diabetes. Then looking at blood pressure, or even patients who are on specific antihypertensive drug treatments, and then looking at those triglycerides, as well as a low HDL. And when we look at this algorithm, we see that yes, they have less I'm sorry, they have at least one out of those five. And are there any other causes for steatosis that we have seen in our evaluation? And when we see no, we see that that is described as MASLD. When we look over at that yes column, we see that that may be a combination of alcoholic liver disease. And then when we see in that no column, are there any other causes for steatosis? Yes, maybe etiology such as monogenetic diseases or DILI. And then when we get way over to that bottom side, we see cryptogenic disease. Once again, that's sort of where we lie in that place of unknowing of exactly what caused that steatotic liver disease. So this new nomenclature, how is it going to change and affect my practice? Well, there aren't a lot of changes to the guidelines with the new nomenclature. The biggest changes are likely how we communicate with our patients. We're pulling out of that stigma of fat, and we're also pulling out of that stigma of alcohol, because I don't know about you, but I have lots of patients who walk in and they say, I've never had a drink of alcohol. How do I have this? This non-alcoholic fatty liver disease. So I think that actually gives us a new opening to say this is a metabolic dysfunction associated steatotic liver disease. It doesn't necessarily have to do with alcohol or with increased fat, but sometimes I find that our patients understand that a little bit better. Studies suggest 99% overlap between MASLD and that NAFLD defined populations. Like I said before, practice guidelines can be applied to MASLD and MASH from that NAFLD. And all of those natural history and biomarker validation studies really just fall into place with MASLD and MASH like they did with that NAFLD and NASH. So I think this is a really nice slide in that it says, hepatic steatosis plus a cardiometabolic risk factor gives you the definition of MASLD. So once again, we're looking at least one out of these cardiometabolic risk factors. Words sometimes, get all crazy, but at least one of these five, BMI, looking at fasting glucose, pre-diabetics or diabetics, looking at that blood pressure or a person on treatment for hypertension, looking at those triglycerides, or are they on a lipid lowering agent? HDL less than 40 for men or less than 50 for women, and once again on that lipid lowering agent. And this excludes patients with alcohol consumption. And remember, we just talked about that, of greater than 20 to 30 grams per day in men or women. Remembering that it's not a lot when we talk about ounces, when we talk about alcohol. So steatotic liver disease suspected. What can we look for with primary care, and how can they be helpful in getting and becoming that first line person who's looking at somebody and thinking, I feel like these people or this person or this patient might have MASLD. So from a primary standpoint, how or when can steatotic liver disease be suspected? And they can take the lead by recognizing patients who meet the criteria with imaging and at least one of the cardiometabolic risk factors. And one of the easiest and a great place to start for primary care management is doing a FIB-4 score. Really easy. Typically with most labs, you can find that FIB-4, and you can take that and you can go forth with that as primary care. So when we look at that FIB-4 score and we see, is it greater than 1.3? That's sort of our baseline where we're looking to either go upwards or downwards. And if it isn't greater than 1.3, then we can say in primary care, reassess with FIB-4 1 to 2 years if there's diabetes type 2 or pre-diabetes and greater than 2 metabolic risk factors. If there's no diabetes or type or pre-diabetes, no metabolic risk factors, then every 2 to 3 years they can reassess that FIB-4, which gives you a really great indication of moving forward and whether that patient potentially has fibrosis. Now, if the FIB4 is greater than 1.3, then we can do some additional non-invasive testing. We can look at elastography, or we can look at another blood test called an ELF. A lot of primary cares don't necessarily have that elastography potential, but maybe in their community, there is a place where they can send that patient for elastography. And if not, so for instance, in my practice, we actually don't have that capability to do elastography. So if I find that there's a FIB4 that is greater than 1.3, then I do go to that ELF and I see what that looks like. And once again, we're looking at that low risk. If there's an opportunity for elastography less than 8.0 or ELF less than 7.7, we can really redirect into that primary care with every 1 to 2 years or every 2 to 3 years. If we see that that FIB4 is elevated, and then we've got an elevated ELF or an elevated elastography, persistently elevated liver enzymes, that's when we want to redirect to hepatology care or GI with hepatology in that goal of identifying and managing patients at risk with MASH or potentially cirrhosis. So we've gotten to this place. We've maybe done a FIB4, maybe we've done an ELF, and we suspect that there's advanced fibrosis. So what I really want you to focus on here is the right side of the screen if you're looking at it. And we're looking at that stage 0 to 1. That is that reassesses in every 2 to 3 years. What I really want to say in the big takeaway from this slide is catching patients in that F2 to F3 range. Because when we do that, then we can actually change the trajectory of their illness. And then this is a reassessment annually, and maybe we even look at some pharmacotherapy. And there's some really great choices that have come out more recently that make that available to us for patients that we find have F2 or F3. When we look at F4, we're looking at that cirrhosis-based management every 6 months with imaging and laboratory work, possibly evaluating for HCC. So when we have advanced fibrosis, would we consider biopsy? That looks when we find that some of those non-invasive tests are indeterminate, or there's diagnostic uncertainty, persistent enzyme elevation. Say we're not sure, we're seeing this imaging that looks like maybe they have nodular contour, but we're also seeing that with our FIB4 or our ELF that their fibrosis score is stage 0 to 1. That might be a time where we look at reassessing and doing a liver biopsy. But we're really starting to move away from that and using that non-invasive testing more frequently. So I think this is a very interesting slide when we look at global epidemiology. Man, words today are just, they're not coming as well as I'd like them to, but you get what I'm saying. Global epidemiology. So what this is really showing us is that this is a global epidemic. It is not just something that we're seeing here in North America. We're seeing it throughout the world. And there is evidence that MASLD is predominant so many places in this world. I was listening to someone the other day who was saying, this does definitely give us the opportunity to know that we will be working for a long time, but it's also giving us a place to say, we need to jump on this and we need to get a handle on it. So when we look at this natural history, we see MASLD in 60 to 80 million Americans, and then advancing into that MASH at 15 to 20 million. And what I really want to say here is that progression is variable. We don't really ever know exactly what is going to have a person progress more quickly through stages and become more fibrotic. We can look at the statistics where it says 1 stage per 7 years with MASH, and 20% of patients are fast progressors to cirrhosis in 10 years. But we also know that steatosis in itself can be a benign process, but as other factors are added, some of those cardiometabolic risk factors, that's when we see that progression to MASLD and then MASH. And then we look way over on that right side and we see 30 to 40% of patients with cirrhosis die from liver disease. So always remember progression is variable, but that is one of the things that we are looking to really intervene with so that we can change that trajectory. Once again, I think these slides are great, but I want to just share with you this sort of MASLD initiation and progression. We see a normal liver, we see it all the way going through to that cirrhotic liver, and then that potential for hepatocellular carcinoma. Steatosis leads to inflammation and hepatocyte ballooning, which over time results in fibrosis and then potentially cirrhosis. Fibrosis is the main driver of prognosis. We see over on that left side some genes that are associated with MASLD, that pineapple gene. But what I want to share and what I hope you can share with patients is that having a predisposition doesn't necessarily mean you will have advanced liver disease. The problem also with MASLD is that it's largely asymptomatic disease in the beginning. But then once we add in those cardiometabolic risk factors, obesity, diabetes, metabolic syndrome, alcohol use, we can see that progression. We can see that progression moving forward to a more fibrotic liver and then potentially cirrhotic. I think interesting also, we see this gut microbiome, bile acid alteration, decreases in microbial diversity, also contributing to that progression of fibrosis into potentially cirrhosis. So when we can stop that process, or maybe slow it down, maybe is a better way to say, at that F2, F3, we can really hopefully stop that possibility of getting to cirrhosis and then maybe hepatocellular carcinoma. So looking at the MASLD guidance from 2023, some of the key points, we've already discussed some of those. MASH plus F2 to F4 fibrosis, higher risk for liver-related events, and mortality at risk MASH. Rates of fibrosis progression and hepatic decompensation really depend on baseline and also those comorbid disease determinants. And then we also need to remember that cardiovascular disease and non-hepatic malignancies are the most common causes of mortality in patients with MASLD. And once again, getting back to that, death from liver disease predominates in patients with advanced fibrosis, 30 to 40%, which is very high to me when I think about it. So let's talk about a patient. Let's talk about somebody that maybe you see in your office on a daily basis. Maybe not daily, but on a weekly basis. So this is JP. He's a 55-year-old man referred for elevated liver enzymes, right upper quadrant discomfort, 20-pound weight gain over 5 years, mostly normal liver chemistries over previous 5 years, mild intermittent elevations of his ALT 45, AST 50, normal alkaline phosphatase, and total bilirubin. He has a past medical history of obesity, pre-diabetes with a hemoglobin A1C of 6.3% and some hypertension. He doesn't have any family history of liver disease. Rarely does he drink alcohol. He works in IT, which suggests that he may have some sedentary habits. He is on lisinopril, and on exam, he has central adiposity with a waist circumference of 110 centimeters, and that translates into a waist circumference of about 43 inches. So when someone like this comes into the office and it's in the primary care setting, they've got a lot of that information already suggesting that this patient may have MASLD. So let's take a look at the evaluation. So we've got a laboratory evaluation here. And when a patient like this comes into my office with elevated liver enzymes, we do a full serological workup. And sometimes I say, we're actually going to be going through an expedition with your blood. We're going to be looking for other factors that could be related to or showing us that you don't have MASLD or that you do have MASLD. And I think I actually skipped a slide, so I'm going to go back. Oh, no, I guess I didn't. Okay. So laboratory evaluation, what are we looking for? We're going to look for some viral hepatitis serologies. We're going to look at ferritin, iron saturation, transferrin saturation again, AMA, And we're going to look for celiac panel. ANA, we're going to look for smooth muscle antibody. Alpha-1 antitrypsin, CBC, CMP, INR, HIV, a lipid panel. What I always also like to remember, especially if I'm seeing a patient later in the day, I want to ask how long it's been since they've eaten. And if it's been just an hour or two, I might actually suggest that they come back to do the panel that we're prescribing. That way I can get a really good look at that lipid panel, hemoglobin A1C, thyroid function, and then PEth, which is a really nice way to look and see if your patient has been really honest with you with regards to their alcohol usage. This gives us an idea what their alcohol usage has been over the past couple of months. So then we also see here some abdominal imaging with ultrasound. We see that the liver looks diffusely echogenic. And then we also see that the liver is a little bit brighter than some of the other organs, which does suggest steatosis. And then we see on the side that the ultrasound only detects moderate and severe hepatic steatosis. Oh, ultrasound-based imaging only detects. So we can actually, though, see some of those things already just from looking at them ourselves. And yes, the ultrasound of the liver does show increase in hepatic echogenicity and typical regions of focal sparing. Fat can be patchy. It doesn't necessarily distribute equally throughout the liver. The contour appears smooth. That would suggest that we don't have nodular contour, maybe advanced fibrosis or cirrhosis. The spleen is normal in size, and then the impression is hepatic steatosis, no evidence of portal hypertension. And when we see no evidence of portal hypertension, once again, that suggests that there isn't advanced fibrosis or cirrhosis. So once again, we're going to come back to that, which patients still need a liver biopsy. And I'm going to say it really depends on if there's indetermination or if there's a discordance with the non-invasive testing that we've done. Say, like I'm coming back to what I said before, if on ultrasound there is a nodular contour, but yet when you do your FIB4 or your ELF and the staging suggests only say F1 or F2, that is a discordant evaluation between your liver ultrasound and your non-invasive testing with blood work, for instance. So that may be a reason to consider a liver biopsy. Also, say your AMA or your smooth muscle antibody is elevated and you want to evaluate for, say, PBC or potentially for autoimmune hepatitis. That would be another reason why you might look to doing liver biopsy. But once again, we're really trying to move away from that. That used to be much more first line, but now we're looking at that non-invasive testing because we're able to get very good, precise results with that non-invasive testing. So getting back to that algorithm, I am a big algorithm girl, love it, think it's awesome when I can check stuff off. So we're here with our patient JP, and we've seen with imaging that he has steatotic liver disease. Yes, there are other causes of steatosis. He has an elevated BMI. He is a pre-diabetic. He is on antihypertensive medication. And so, yes, this does suggest that he has metabolic dysfunction associated steatotic liver disease or MASLD. So we kind of just answered all of these questions. Does this patient have underlying steatohepatitis? More so, it probably looks like he has MASLD. It doesn't look as if he's progressed to MASH. Does the patient have any fibrosis? We aren't necessarily seeing that because we don't have an ELF score here to know if he has fibrosis. And does this patient have advanced F3, F4 fibrosis? Once again, we don't have that laboratory work to suggest that, but that is something that we can go forth and look at next. We may have done that FIB4, and if it was significantly elevated, then we could potentially say, yes, he may have advanced fibrosis. But then if we look at elastography, or if we also look at that ELF, that gives a better delineation of whether this might be that F3, F4, or even F2, F3. And really, just to summarize here, what I want to say is that This new nomenclature, MASLD, MASH, really helps to reduce stigma and helps us to get a better way of diagnosing this patient. In the primary care setting, this enables them to be on that front line because they're seeing these patients on a daily basis. And they can then take control and start to do that evaluation looking towards that MASLD. MASLD is the most common cause of liver disease worldwide. We saw that with that epidemiology, and that it's not just in North America. Fibrosis is the key determinant of prognosis. When we want to take a look at someone who has F2, F3, we want to really just jump on that and get them looking at lifestyle changes, maybe moving their body more frequently, maybe looking at the Mediterranean diet and making dietary shifts so that they can do those lifestyle changes. And then we've seen this algorithm, which is a great stepwise evaluation starting in primary care. And then by starting that in that primary care setting, it helps patients to get to that right level of care. Do they need to be transitioned over to hepatology, or can they stay in that primary care setting and be reassessed with a FIB-4 every 1 to 2 years or every 2 to 3 years, depending on their comorbidities and those cardiometabolic risk factors? So many good things are coming with this new nomenclature in that it's, once again, reducing the stigma of alcohol usage or fatty liver, for instance. We may still use that in our practice to help patients understand the nomenclature change, that it's steatotic liver disease, but maybe looking at that metabolic dysfunction as opposed to that alcohol-related dysfunction. So thank you so much for listening to me. I really, really appreciate it. You can visit the GAP and MASLD MASH Community Network for additional disease state education, and the Resdifra webcast, which is one of the pharmacotherapies that we have available to us now with F2 and F3. And then also, if you want to complete a short survey, share your thoughts on today's presentation, letting me know what you thought. Always open to constructive criticism. Actually, not criticism, that's not the best way to say it, but constructive advice. But thank you so much for listening. Really appreciate it. And I hope wherever you are in your day that you're having a great day. Thanks so much.